دكتور عبد الرحمن، الو.
السلام ورحمة الله وبركاته.
حياك
واضح
الله.
الصوت دكتور؟
جدا واضح. صوتي واضح؟
جدا جدا واضح.
يعطيك العافية.
طيب الله يعافيك. مساء الخير جميعا. مرحبا بكم جميعا في اليوم الخامس والأخير من كورس العلاجيات في الأورام. بإذن الله اليوم عندنا 4 محاضرات شيقة جدا. راح نبدأ بإذن الله في المحاضرة الأولى اللي هي Basic Introduction to Transplant and Cellular Therapy by Dr. عبد الرحمن الغامدي. The second lecture will be Biosimilar and Oncology, will be presented by Dr. Amr Khardali, and the third presentation will be Safe Handling of Hazardous Drug by Dr. Abdulaziz bin Abeid, and the last lecture will be Medication Safety and Oncology, which will be presented by Dr. Ali Malhan. For now, we are going to start our first lecture, which will be presented by Dr. Abdurrahman Al-Ghamdi. Dr. Abdurrahman is a consultant clinical pharmacist specialized in hematology, oncology, stem cell transplant, and cellular therapy, and a residency program director in oncology and hematology in King Abdulaziz Medical City in Riyadh. Welcome, Dr. Abdurrahman, and you can start now. Good luck.
Thank you so much, Dr. Abdurrahman, for your introduction, and thank you, Suba, for their invitations. Just today actually, and أرحب بجميع الحضور من أنحاء المملكة سواء على اليوتيوب أو على الزوم application. Actually, to talk about stem cell transplantation and cellular therapy in 30 minutes, this is very difficult. This topic, it is a course by itself. And it's need in the college, I teach it in the college in 2 hours. But I try to summarize it and talk about tips and basic information that give the student, while most of the audience is student, background and to be familiar with stem cell and cellular therapy. Usually stem cell Bismillah ar-Rahman ar-Rahim. This is my objective and disclosure. I don't have anything to disclose. It is usual to have the stem cell transplantation at the end of the course because it's really the last resort and the last option of treatment after failure of all chemotherapy, conventional and non-conventional, targeting therapy and everything. This is the last resort. So here I will talk about the concept of hematopoietic stem cell transplantation, basic of HLA matching, therapeutic goal, different types of SCT, indications, rule of conditioning before SCT, expected outcome from SCT, most common related complications, and at the end I will talk about 2 things: cellular therapy, which is CAR T-cell, and the Saudi stem cell donor registry. I hope this presentation will be, you enjoy it and benefit from. Actually, if I ask you or ask most of you, especially students, about the history or how old is this SCT, most of them maybe will say 5-10 years. But actually, stem cell transplantation, it's more than 60 years of clinical experience. It started in 1950, last century, on experimental observational study on mice or animal. And shortly after that, start immediately in human application, clinical human. And the first acute leukemia transplantation, it was syngeneic from identical twin transplanted in 1957. The father of stem cell transplantation is Dr. Thomas. Actually, this is the father of SCT with multiple researches started from 70s last century until 1990. He got the Nobel Prize when he did the first successful allogenic stem cell transplantation in Minnesota, US in 1968. Afterward, the stem cell transplantation became a standard of care among the worldwide. Actually, Saudi Arabia, it's one of the unique country, walillah alhamdu wal minna. It is one of the known countries of Arab countries that participating in Center of International BMT Research. If you see the history, it started in 1980 almost. It was almost only autologous, or most of the cases was autologous because the problem of donor for allogenic. Then when the registry of stem cell donor registers start to give the chance, they become parallel. This is the graph show just in the US, the number of transplantation based on type, MUD or related or unrelated. This is the opposite in Saudi Arabia. Actually, we are related more than unrelated donation or stem cell transplantation. This graph also show you the diseases that stem cell transplantation treated. The majority always, even here in Saudi Arabia, it is multiple myeloma and lymphoma because it's easy to have the graft from the patient himself as autologous. And this type of disease is very sensitive to chemo, to give mega dose, then re-infuse the stem cell transplant from the patient. For after that, leukemias, but it need donor and this more complicated. I think this graph, it's been explained many times throughout the course in the last days, but here I would like to just highlight one point. This is stem cell. Actually, before this point, before this step, there is pluripotent stem cell. This has a capacity to produce any type of tissue, but this hematobiotic is special for blood. This is the bone marrow part until this red line. And it is two-part myeloid stem cell and lymphoid differentiated. After this line, it will be in the circulation as end user or end product as RBCs, platelet, and so on. This is the peripheral blood. So the beauty of stem cell, it is self-renewal, pluripotent, and it is replicate the bone marrow when damaged. Sometimes in stem cell, we damage the bone marrow intentionally to treat the patient. So then re-infuse the stem cell to proliferate. Some definition for students, especially autologous SCT, it's clear now. It is patients themselves. Stem cell will be collected, frozen, stored, then re-infused to the patient. Allogenic is the opposite. It's donor related. Could be related or unrelated donor. Chimerism, it is a genetic analytic test that we test the engraftment of the new stem cell that we transfuse it to the patient to see it is successful or not with this test. Conditioning regimen, it is the anti-neoplastic, either radiation or chemo or both, given prior to stem cell engraftment. It has a definition in white cells and platelet. Al-inzira, yani we said this patient engrafted, that's mean that the cells we give start to grow with certain criteria. Graft failure, it is one of the nightmares for us. It's loss of the donor cells. And this happened, one of the complications of allogenic SCT. GVHD, it's a complication, very common in allogenic. It is only allogenic, actually, when the donor cells start to recognize the host body, the whole body, as a foreign body and start to attack either liver, gut, and skin, whatever. GVT, this is a good response, which is graft versus tumor activity. This is the idea behind allogenic transplantation. So what's stem cell transplantation? Because some people thought it is a surgery. Some patient, بعض المرضى يجونا في المركز يقول بتفتحون العظم يعني بالجراحين وتطلعون النخاع ومتخيل الستم سيل بالشكل هذا. طبعا it is not surgery. It is like blood transfusion. We will take the stem cell either from the patient himself or from donor and infuse it into a patient after being appropriately prepared with chemorad, we call it conditioning, to eradicate the remaining disease and reset the host immune system to accept this SCT, what is the graft. Usually through central line, Hickman line, most commonly, infused through the bloodstream, and this stem cell will go through the bloodstream down to the bone marrow and will settle there for 14 to 21 days plus minus And after that, will start to proliferate itself and engraft all type of cells, start to grow the platelet, the white cells, the RBCs, and so on. So it's as simple as that. This is the stem cell transplantation. This is actually the orange color. It is the one infused to the patient with hydration, and that's it. But there is conditioning before this, and we will see. What's the type of SCT? It is autologous from patient himself or allogenic. Allogenic, there is based on the source, either match-related or match-unrelated donor or cord blood, which is umbilical cord blood, اللي هو دم الحبل السري يكون غني جدا بالستم سيل بالخلايا الجذعيه فيتم الاستفاده منه. وطبعا عندنا في المملكه بنك في الحرس الوطني في بنك للحبل السري ودم الحبل السري. Haplo identical, this is half matching, 50% matching, either parent to the sons or the opposite. So we know now the autologous it's patient themselves, allogenic, this types, the match-related donor always or most of time siblings, الأشقاء، الأخوة والأخوات الأشقاء، الsource تبعه. Match-related donor, usually اللي مريض مثلا ما عنده أخوة وأخوات مطابقين، نبحث عن مطابق غير قريب. طبعا هذا يكون موجود في الستيم سيل بانك أو اللي نسميه احنا Registry، السجل الوطني. Umbilical cord blood donation أو من الحبل السري بعد الولادة مباشرة تكون الأم وافقت على التبرع. Haplo identical donor, this is 50%. Syngenic, this is identical twin اللي هم التوأم المطابق. This is considered a donor, but in the same time, the property of syngenic consider autologous because they are genetically exactly the same. Okay, that's the MRDs. So here the alternative donor sources, either MUD, match-related donor, cord blood, or haploidentical. This is the variation between them. For example, if we said like to have a second donation, it is possible in MUD because the donor is there. It's possible in haploidentical, the donor is there, but it's not possible in cord blood because you got the cord blood and that's it. So every type has its own advantages and disadvantages. So HLA typing, this is very important. What's HLA typing? المطابقة. قبل ما نزرع لازم نعمل مطابقة ونتأكد إنه مطابق المريض مع المتبرع. HLA, it's human leukocyte antigen. It is a system or immune system and the gene complex located in human in short arm of chromosome 6. The responsibility, it is encoding major histocompatibility complex protein in human. It is highly polymorphic. مختلف جدا بين البشر لذلك مو أي واحد يقدر يتبرع لأحد. لابد من مطابقة ودراسة لأن إحنا مختلفين عن بعض. Very polymorphic. So there is low resolution HLA typing and high resolution actually. Before that, we have 3 locus A, B, C. This locus or the part of the HLA antigen, we call it class 1 HLA typing. And there is DRB1 loci and DQB1. This is we call class 2 HLA typing. So we need to match all of this. This is 5 paired 10 alleles. When we like to do high resolution, we look for genetic characteristic, what we call it allele, مورثات. So this is example for MRD, this match related donor. If يعني لو شخص بيتبرع لأخوه الشقيق أو أخته الشقيقة. This is the father HLA type and this is the mother HLA type. This is for sons or kids. One of them is sick. Let's say this has leukemia here and has 3 siblings. They like to donate for him. Which one of those is the best to donate? Actually, this one is not matching. It's 50% only. This one also is 50%, the violet color, 50%. This one is 100%, not 100, but 10 out of 10, we call it, matching. If you see it is brown with violet, this is just to explain how is it, but it's not like this, it's numbers, figures, genetic. So this will be MRD, the most potential donor to donate for his brother or sister here. This is the MRD. let's say this is the father and mother, and this is the patient, and all siblings are not matching with their brother or sister, okay, the patient. So what we will do here, we have two solutions, either to do haplo, because you are half of your father or half of your mother. You can take haplo identical from your mom or haplo identical from your father. If not, but we don't prefer haplo first. Actually, before haplo, we prefer to have MUD, match a related donor. We look in the registries for someone who's 10 out of 10 matching our patient and use the cells, because the outcome better and the complication is less. So this will answer the question, which the most prior or the donor priority in allogenic stem cell transplantation. For sure, match-related donor sibling is the best outcome. Then number two, second, is MUD, match-related donor. After that, we will look for haploidentical, either the father, mother, will donate for the kids, or the kids will donate for the parent. The HLA mismatch, either related or unrelated, is very worse outcome and a lot of complication. So what's the step of stem cell transplantation, the procedure itself? Let's recognize between the autologous and allogenic. In autologous, we will start here. This is the patient himself will reinfuse his stem cell. So we'll give chemotherapy as a treatment plus G-CSF 10 mic per kg plus minus plerixafor, the mosabil or the mobilizing agent in hard mobilizing, hard collecting patient. And we will collect the patient. This is the first point. When we collect, we'll take this stem cell, put it in the freezer, store it. Then we'll do further treatment until, for lymphoma, for example, until we reach complete remission or very good remission. Then we'll give the conditioning, the chemo before transplantation. Then we will reinfuse the collected stem cell that we collected before. Bring it from the fridge, thaw it, then infuse it to the patient. The idea here, just to give mega dose of chemo to eradicate the disease, and then rescue the bone marrow. يعني تنقذ البون marrow. لأن إذا أعطينا mega dose of chemotherapy here, the bone marrow will never recover unless we reinfuse a stem cell to repopulate it. So the idea is rescue. What's the story here in the allogenic stem cell transplant? The HLA typing is the first point. Sometimes when patients come admitted to the hospital and we diagnose the patient as acute leukemia especially, we start to look for his son and brothers to do HLA typing, preparing for stem cell from the first day or first day of diagnosis, because most likely patient will be in need for stem cell with the difficult diseases. So first typing, then donor selection. We will look for donor, see the most potential donor and fit for donation. Then we'll give conditioning. During conditioning and 4 days before transplantation, we will bring the donor consented and collected with G-CSF only, not allowed to give chemo to donor for sure. So then we'll take this graft from the donor and give it to the patient. So here the beauty of allogenic, even it is more complicated, but it carry graft versus leukemia or lymphoma effect, which is lacking here in autologous. So what's the place of therapy in SCT? It could be first line or salvage. But why SCT is the last resort? Because, as Dr. Abdullah Rajhi mentioned it yesterday, it's really a risky procedure. The mortality rate in allogenic transplantation could reach 40%, minimum less than 10%. But it's risky, so we will not use it except if the benefit outweigh all risk and patient fit, and we have a fit donor. So it could be first line in two cases. Either the disease is chemosensitive, so we'd like to give mega dose and then autologously give back the stem cell to rescue the bone marrow, or a disease that not treated well, like high risk adult ALL, there is no treatment. Actually, the hope to have cure, it's very low, so stem cell upfront could be. Salvage, it's most of the disease salvage. We try with chemo, targeting therapy, whatever, If we fail, we'll go to the stem cell as salvage therapy. So allogenic, it's donor-based and carry GVT. Autologous, it is only the idea high dose, then rescue the bone marrow. What's the advantage, disadvantage? The big advantage, as we said, GVT. And the disadvantage, it's difficult to find a donor sometimes, GVHD, chance of rejection, and so on. For autologous and syngeneic, which is identical twin, no GVHD, complication is less, but no GVT as well, no graft versus leukemia. The graft will not recognize the cancerous cells and kill it. So the common sources of stem cell transplant, the old way is bone marrow. You collect from the bone marrow itself, and this historically in 1960, it was the one. The modern one is peripheral blood stem cell collection through a machine, apheresis. The third way is umbilical cord blood. You collect the blood and do typing, put it in the bank. This is the bone marrow harvesting. It was in the past manual. The physician will push hard to push this Jamshidi needle to have a stem cell and make sometimes 20, 30 bores in the iliac crust bone. But now it's used drilling machine. It is easier, but in the same time, this is very painful. Patient will be in the OR under general anesthesia. The modern way and the most comfortable to the patient is the apheresis peripheral blood. It's a machine like a hemodialysis machine will take the blood, centrifuge it, take the stem cell here in the bag, return the remaining blood to the patient. But here you need to give GCSF. Indication and example of indication of stem cell, they are hundreds, but this is the common indication. Bone marrow failure like MDS, for example, hematological malignancy, lymphoma, leukemia. Non-hematological mean solid tumors like Ewing sarcoma, germ cell tumor, and we do all this in our center. Other benign condition like sickle cell anemia, like autoimmune diseases, like multiple sclerosis, and we did some cases with autologous for sure. So autologous, the indication, when the disease you are treating, it's very sensitive to chemo. So you like to give a mega dose. So if this amount of chemo will give you this amount of response, this amount of chemo will give you this amount of response. So that's why you give a big amount of chemo dose, but this will be on the cost of bone marrow. Here could happen a death secondary to bone marrow, and this is acceptable because you have the modality to recover the bone marrow by the stem cell. But it's completely unacceptable to have death secondary to other organ toxicity. So this is a normal chemo we give for treating. This is conditioning chemo to eradicate completely the disease and the bone marrow, but this is not acceptable. This is a toxic level to all organs. This used in lymphoma, multiple myeloma, and autoimmune. What's the outcome? Outcome is excellent. Aggressive type of lymphoma, for example, this is a rough estimation for outcome. The cure for relapse refractory Hodgkin lymphoma, for example, increased from less than 20% to more than 50%. This is excellent. And 5 years relapse-free survival, it is more than 50%. Mortality rate is very low because it's very safe procedure. Even we are now doing the all autologous transplantation in the outpatient setting because it's easy, not complicated, and safe. Most failure happened secondary to relapse related, but not to procedure related. Allogenic is the opposite. What's the diseases treated? It is the malignant diseases that with bone marrow involvement. The beauty here is GVT, graft versus tumor, immunologic activity against cancer. So example, leukemia, lymphoma, and the non-malignancy, either to treat the defected hematopoietic like MDS, or to suppress the immune system in autoimmune disease like multiple sclerosis, and this is the examples. So what's the outcome in allogenic? Still good, but it's vary depending on disease type, the graft type, mod, hablo, or matched sibling. patient performance status as better outcome. Example, the cure rate for sickle cell, it's excellent, very bright. It is 95%, more than 95% in young adult. While in a relapse refractory leukemia, it's less than 5% to survive 5 years, but here we can reach 40 or 50% with high risk leukemias. Mortality rate is very high, 10 to 40%. Most of centers is 10 or around 10, rare to have 40. Most failures secondary to the procedure itself, not to the relapse. So infection, sepsis, and so on. This is, sorry for this busy slide, but it's very beneficial. I summarize most of the things here. So major complication of an allogenic transplantation is GVHD, infection, and VOD. There is other complications actually, like mucositis, hemorrhagic cystitis, and so on, pulmonary toxicity, but this is the major common. So GVHD, acute or chronic, when it's happened, frequency, risk factor, prevention. So prevention with the immune suppressant, calcineurin inhibitor plus minus MTX or ATG. For treatment, steroid always for treatment, first line. If steroid refractory, then in acute we'll go for ruxolitinib, and for chronic we'll go for ibrutinib. To prevent a chronic, treat or avoid to have acute GVHD. Infections, too many, could be bacterial, fungal, mold, invasive fungal, CMV, BCB, herpes simplex virus, and so on. VOD, this is very serious complication, especially if it is severe. And the only treatment is defibrotide. And you need to be very vigilant to diagnose it very early, the first sign. So stem cell in brief, it is when you fail chemotherapy, targeting therapy will take patient to stem cell, either allogenic or autologous for chemosensitive diseases to give a mega dose, then rescue the bone marrow. For allogenic, you take the patient to have the graft of the donor, because the problem in leukemia, for example, the immune system of the patient, T cell especially, could not fail to recognize the cancerous cells and attack it. So you have a graft from outside with T cell, hopefully this new T cell to recognize the cancerous cells and kill it. Now the new modality really, this is the hot issue now worldwide, is cellular therapy. There is drugs called immunotherapy, like nivolumab, pembrolizumab, PD-1, PDL, but this is cellular immunotherapy. It is not a drug, it's a drug conjugated with T cell. It's a new era called CAR T cell, which is chimeric antigen receptor T cell. Sorry, I'm very in a hurry because the time. It is the latest model of cancer. Treat cancer with no harm to normal cells. This is the idea. Genetic engineered auto-SCT, because you will have the patient T cell, then resume it to the patient, return it back. So far, we have 2 US FDA approved drugs. It is very promising with excellent outcome, no GVHD because it's autologous, but the cost is cytokine release syndrome and CRES, which is encephalopathy in the first month especially. CAR T cell treating 2 diseases so far, non-Hodgkin lymphoma and B-cell ALL. But the pipeline is full with the drugs coming on the way. This is the 2 drugs, tisagene licleucel, which is a cytotoxic T lymphocyte, direct attacking the CD19 positive B-cell called Kymriah from Novartis company. For treating both lymphoma and acute leukemia B-cell. Outcome is excellent so far. All patients almost have cytokine release syndrome. The second drug is Yescarta from Gilead company. Also, both of them approved in 2017, 3 years ago. But Kymriah is the first. This treating only lymphoma and the same target, CD19. So how to produce this CAR T cell? Actually, it starts from the patient apheresis. You collect the leukapheresis, collect the patient white cells, extract the T cell, and send it abroad to the manufacturer, Novartis, for example, for Kymriah. They will take it in the lab, and the manufacturer, they will do reprogramming to the patient CAR T cell. How they will do it? They will have the T cell and the drug, which is TISA gene Liclusil, for example, Kymriah, which is a marker. They will try to engineer it or program it with the T cell of the patient using viral vector, which is lentiviral, which is AIDS viral, inactivated, to transduct the gene combination inside the nucleus of the T cell. When the T cell be ready and already ready to attack the cancerous cells, they will take it and multiplicate it, grow it, make it millions of number per patient kg. When it's ready, they will take it to wash it out or cleaning of any unnecessary material. Will be ready now as CAR T cell, which is T cell with the drug TISA gene Liclusil, can recognize the cancer cell and attack it. But before to give it, you need to give chemotherapy, usually fludarabine with cyclophosphamide 3 days before, 2 days for 3 days, but 2 days before to give that T cell. So day -5, we will give fludarabine cyclophosphamide. Day -5, any days before transplantation conditioning, we call it minus. So -5, -4, -3. Then -2, -1 will be rest for the patient. Then day 0, we will give the CAR T cell. And this is the same idea for transplantation. The cost of this CAR T cell for one patient, it $500,000. يعني تتكلم عن 1,800,000 ريال سعودي to produce one product for one patient. It's very costly. And the waiting list in Novartis company for Kymriah is very long. It's very difficult to have this. When you infuse it, it will start attacking the cancerous cells. Actually, this is not free, but the cost of toxicity. It has 2 black box warning, which is cytokine release syndrome and CAR T cell related encephalopathy. And there is manifestation severity based on grading system, which is called CARTOX, to grade the toxicity, which is grade 1, 2, 3, 4. 1, it's fever or constitutional symptoms. This is easy, you give just antibiotic and hydration. But if it is stage 2 and but oxygen less than 40% demand, you must give tocilizumab here and supplemental oxygen with fluid. By the way, if you don't have tocilizumab in your center, you are not allowed to do CAR T cell. This is very essential drug. It is interleukin 6 inhibitor or blocker used in cytokine release syndrome. Should be there, available all the time in all center with CAR T cell. If it is grade 3, we'll give vasopressor and transfer to ICU. Grade 4, mechanical ventilation. So another toxicity, it is neurological seizure, generalized tonic-clonic. Actually, this is not that, this is common cytokine release, but for seizure or neurological toxicity, it's rare in CAR T cell. But you must give all patients levetiracetam 750 milligram Q12 on the day of CAR T cell and continue for 30 days after CAR T cell. Also, there is a criteria called CARTOX 10 for neurological toxicity. It's subjective, very subjective. You ask the patient about the president, prime minister, about the year, the month, the city. You have this point, calculate it, and put it in this schedule. If CARTOX 10, 7 to 9, as higher as better, it is mild. Not that much to do, but you consider tocilizumab as well. If it is, especially if there is CRS. CARTOX grade 2, 3 to 6 point, tocilizumab is a must. Grade 3 ICU admission with especially if it is, and also consider corticosteroid. Also in CRS grade 3 and 4 corticosteroid you consider, but grade 4 for sure you give corticosteroid. Why we don't like to give corticosteroid in post CAR T cell? Because this will weaken the T cell of the CAR T. That's why we avoid it, and we try to avoid it unless it is a must and life-threatening. Finally, we'll talk about, أنا صراحة بستغل وجود ما شاء الله العدد الكبير من الطلبة والأخوة الزملاء اني اعمل كومبين او يعني حمله للسجل السعودي للمتبرعين بالخلايا الجذعيه Saudi Stem Cell Donor Registry. It is two branches, cord blood bank and stem cell pool. Actually, it is under umbrella of National Guard, Ministry of National Guard, under umbrella also في مركز الملك عبد الله العالمي للأبحاث الطبية. We have our partnership with our colleague in US and Germany. We are part of it. They can utilize our bank and we are utilizing there. So we started the registry in 2011 with very few number of donor, and بفضل after 7 years, now we reach more than 70,000. This is all 2018, sorry. Now we are more than 70,000 donor in our registry ready for donation. So our goal is 10% of Saudi population, which is more than 3 million donor. إن شاء الله بهمتكم نصل إلى هذا الرقم. إيش يستفيد المتبرع إنه يتبرع؟ طبعاً أولاً reward from الله، الأجر من الله سبحانه وتعالى، ومن أحياها فكأنما أحيا الناس جميعاً. self satisfaction، أنت تشعر بالسعادة لما تنقذ حياة إنسان، وهذا for sure. Free medical evaluation, donation and free health care. يصير لك يعني بطاقة وتصبح من التابعين للحرس الوطني في العلاج بوست دونيشن، أو حتى عندنا البارتنر مع جميع المستشفيات طبعا بما فيها وزارة الصحة والأدرس. كينج عبد العزيز ميديكال كينج عبد العزيز ميدال أسامة الملك عبد العزيز من الدرجة الثالثة تمنحه، وأيضا small gift and certificate. Actually, I encourage everyone to disseminate this to your friends in the college, at home, everywhere. The registry is to campaign from time to time in the malls, in the hospitals, everywhere in the kingdom. And إحنا نطلب همتكم أنكم تنشروا هذا الكلام، registry هذه، تنشروا الثقافة هذه بين الشعب السعودي كامل، لنصل إن شاء الله إلى أن يكون عندنا registry وبنك للستم سيل كبير جدا، بحيث انه بالذات الاطفال اللي اول مولود او ثاني يصاب بالليكيميا خصيصا ما يكون عنده اخوه مطابقين، فالحل ان نبحث عن ريجستري او البنك هذا. ايضا الناس اللي ما عندهم، حتى لو عنده اخوه ما عنده، يعني this is a very good solution. يعني US for example they reach 30 million donor. For us hopefully inshallah to reach 10% of population. It's scattered over the kingdom everywhere. This is the contacting number and the social media. This is my references and thank you.
ما شاء الله تبارك الله، يعطيك العافية دكتور. Thank you very much for this very informative and a comprehensive introduction to stem cell and cellular therapy. I think يعني all of the audience learned a lot. It is very huge topic. ما شاء الله, and you summarized it over 35 minutes.
Thank you so much.
Thank you, Doctor. For the audience, if you have any question, you can write it down in the question and answer chat.
ناخذ الأسئلة للأودينس عبد الرحمن بعد إذنك.
إيه تفضل دكتور.
لا الأسئلة اللي أنا أسألهم بعدين نشوفهم أسألوا إيش. أيوة. Question number 1. The therapeutic goal of allogenic stem cell transplant in a leukemia patient is based on the following strategy. تكلمنا عنها كثير. المفروض إنه الآن at least الأودينس يعرفوا يميزوا بين الألوجينيك والأوتولوجاس، إيش الفروقات اللي بينها. ضروري يعني الزراعة الذاتية أو الزراعة من متبرع. To eradicate all leukemic cell and utilize graft versus leukemia. Excellent. I agree with 55%. Excellent. Next question, please. VOD, we said in a very severe complication, both the highly mortality rate to severe cases. What's the best drug? It's only one drug. By the way, all these drugs has been utilized or tested, but one drug only is the drug of choice and use if they, I'm not sure if US approved or EMA. Excellent, I agree with 41. It is defibrotide, the 41 of you. Excellent. And we mentioned that clearly, actually. The third question is a case, 25 years old male with relapsed refractory B-cell ALL who is undergo CAR T-cell immunotherapy with T-cell gene liquid. Which of the following medication should be initiated on the day of CAR T-cell infusion and continue for 30 days? We mentioned it clearly, actually, but to stress on this point because it's very important for us as a clinical pharmacist or pharmacist. Supposed to be 100% this one. اوكي الشباب مو مصحصحين كثير. طيب لا هو الليفاتاراسيتام لان قلنا الستيرويد بروهيبيتد يا جماعه في الكارتي سيل الا في الحالات اللايف ثريتنينج. الكبرى because of seizure prevention. Excellent. May proceed with Dr. Abdullah Raj في slide for okay.
Doctor, for the question, we have two questions. The first one is CAR T cell available here?
Actually, excellent question. أنا sake of time ولا كنت بتكلم عنه. No, it is not طبعا في المملكة إلى الآن في الشرق الأوسط تقريبا كله ما فيه. موجودة في اليو اس تشاينا ممكن. لكن اليو اس هم البايونير. You have two choices, either to do your own here production, take your patient T cell and produce CAR T cell for it. And in this case, you need to establish the machine, the facilities, the expertise, or what's happening now to send the T cell. I'm not sure King Faisal sent one patient or not, send the T cell to the Novartis or Gilead to prepare the CAR T for you, then they will send it to you to infuse it to the patient. And this will cost $500,000. 1,800,000 للبيشنت الواحد. طبعا اذا نجيبها عندنا في السعوديه افضل وفي بروجكت بيج بروجكت على مستوى البلد كامله ان نعمل الكارتي سيل بروجكت وان شاء الله يشوف النور قريبا.
ان شاء الله على خير. في two question دكتور, they asking about the requirement to be a stem cell donor and if there is any dangerous to be a donor.
Actually no requirement, just to call them, arrange a point and go to the nearest donation registry and they will just take blood sample, see your low resolution HLA type, they will keep it in the bank. If any patient in the future match with you, they will call you and it's optional, it's yours. You can say, okay, I will come and donate, and you can say, no, please withdraw my name from the bank, I don't like to donate. يعني nobody will enforce you. السؤال الثاني عبد الرحمن قال ايش؟ الدينجر very rare. يعني maybe 1 per million to have splenic rupture لا سمح الله مع الجي سي اس اف وthis is يعني اقل من 1 per million يعني very rare شيء لا يذكر يعني الواحد المفروض ما يتكلم عنه اصلا.
Excellent دكتور. Doctor, I think now we are done for this presentation. Thank you again. It was a very informative presentation. And for now, yes, thank you, Doctor. For now, we can. Allah يعافيك. For now, we are going to our second lecture, which is biosimilar in oncology, which will be presented by Dr. Omar Khardali. Dr. Omar is an assistant deputyship for the Therapeutic support service in Ministry of Health. Welcome, Dr. Omar, and you can start now.
السلام عليكم. ظاهر السلايدات؟
اي نعم دكتور ظاهرة.
طيب. السلام عليكم ورحمة الله وبركاته. مساء الخير على الجميع. Good evening everybody. My topic inshallah for tonight is biosimilar in oncology. ممكن أغير التوبيك شوية إلى البايوسيميلر as a concept and as newly introduced to local market, especially للزملاء الطلاب اللي معانا والانترنز والفريش جرادويت. راح اتكلم little bit superficially عن biosimilar in general. Then at the end we'll touch a little bit in regard to oncology. My objectives for tonight is what are biologics, what are biosimilars, and how are biosimilar developed, and finally biosimilar importance, especially for oncology field. Biological drugs are given several definitions by FDA. They divide biological products as diverse category of products and are generally large, complex, and molecules. These products may be produced through biotechnology in living systems, such as microorganisms, plant, cell, or animal cell, and are often more difficult to characterize than small molecule drugs. Small molecule drugs we mean اللي هي الأدوية العادية والchemical drugs اللي معروفة، الأقراص وما إلى ذلك. EMA or European Medicine Agency, which is يعني almost مثل ال FDA ولكن في أوروبا جهة تشريعية فيما يخص الأدوية والبيولوجيكس وخلافه في أوروبا. It gives a definition of biological medicine contain active substance from a biological source such as living cells or organisms like human, animals, or microorganisms such as bacteria or yeast, and are often produced by cutting-edge technology. تقريبا زي ما احنا شايفين we have some match or keywords matching between the two definitions. Both are large, complex molecule and produced through biotechnology system in living cells or living system, microorganisms, plants, and mammalian, and etc. Well, that's why it's given its name a bio. That's given it came from a living system. More specifically, monoclonal antibodies are firstly introduced in last decade and 1984. Three German scientists won the Nobel Prize. استحقوا جائزة نوبل في الطب والعلوم لاكتشافهم طريقة تخليق المونوكلونال antibodies, which called hybridoma technique. تبسيطا how are hybridoma technique run. يحقن أنتيجين في الليفنج سيستم اللي تكلمنا عليه سواء كان بكتيريا yeast or mammalian. Then the immunity system, it will produce antibodies to fighting that antigen. That immuno cells are collected and mixed with a partner cell. Partner cells are mostly multiple myeloma cells. Why they are used multiple myeloma cells? For commercial issues, for indefinite growth. After that, they are infused the mixture again, and at that step we have a multi-clone عبارة عن antibodies مختلفة يتم فصلها sub-clone إلى كل فئة لوحدها، ويتم بعد كذا تجميدها للحفاظ عليها واستخدامها في المانيفاكتشرنج برودكشن والإنتاج على مستويات كبيرة. يتم في الخطوة ما قبل الأخيرة اللي هي البروفيكيشن، تنقية المونوكلونال انتيبوديز هذه من الشوائب ومن الكلونز نفسها، وبعدين يتم ديتكشن لها وبدء تصنيعها في as a commercial quantities. Again, the same thing how it's going biological manufacturing modify الهوست سيل. زي ما تفضل الدكتور عبد الرحمن من شويه في يستخدموا ال HIV cells، تسمى خلايا مرض نقص المناعه ولكنها inactive cells. same situation الادويه اللي تكلمت عنها اول يوم دكتوره نوره في targeted therapy. Those biologics can be produced by mice, by mammalian. عندنا تكون chimeric أو تكون purely from mice and تكون humanized according to source of living according to source of living cell. Then growing the cell, purification, the last step before formulation and finishing the product. When we go from regular medication to a biological medication or monoclonal antibodies, the complexity and the size of medication itself are increased. For example, here we have a small molecule medication. It's a chemical drug. When we compare to biological medication, we can see it's a huge molecules, contain a lot of functional groups, a lot of chemical bonds, and furthermore with the monoclonal antibodies نوعا ما معقدة وتحتوي على مجموعات هائلة سواء كيميائية أو مجموعات روابط كيميائية أو مجموعات فاعلة. مثال بسيط لمحاكاة السايز والكومبلكسيتي اللي موجودة. تقريبا الأسبرين كلنا كصيادلة تعرضنا للدواء، واحد من الأدوية الأساسية وأشهر الأدوية تقريبا وأبسطها من ناحية المركب الكيميائي. في المقابل الغالبية امتلكوا في مرحلة من حياتهم السيكل أو الدراجة. إذا بناخذها نسبة وتناسب، الأسبرين contain of 21 atoms. الدراجة تقريبا 20 باوند في الوزن. فيما يخص السايز والكومبلكسيتي، الأسبرين تقريبا ستراكشر بسيط والتفاعلات اللي سهل حكم التفاعلات. Furthermore, if we go to hormone, human growth hormone, which consists of almost 3,000 atoms, matching 3,000 pounds with a small Mini Cooper car. If we go more to IG immunoglobulin G antibodies, consists of 25,000 atoms, which match almost business jet plan without fuel. Monoclonal antibodies medications that you are using in oncology or in immunology or in gastro are more complicated than immunoglobulin G and more heavier, consist more atoms than 25,000, reaching up to or more than 35 and 40,000 atoms. الأدوية هذه this medication موجودة حاليا في السوق، حققت مبيعات مليارية للشركات المالكة لها والمسوقة لها. فيما يخص الأورام أو الأونكولوجي، we have the Neupogen, we have rituximab as well, bevacizumab, Avastin, Herceptin, and Prolia, Xgeva and الإمبليوماب. كل الأدوية هذه حققت مبيعات مليارية للشركات حقها، وراح تطلع خلال السنوات هذه. في بعض أدوية اوريدي طلعت من الاحتكار، وفي أدوية راح تطلع خلال السنوات القادمة، وأدوية غير هذه غير الموجودة. طبيعي إن يصير في كومبيتيشن من شركات أخرى إنها تدخل السوق هذا، خصوصا إنهم عارفين إن الدواء، عارفين almost structure حق الدواء، وعارفين فائدة الدواء، مثبتة فائدة الدواء والحاجة الديماند له في السوق. ومن هنا جاءت فكرة البايوسيميلر. طيب what are biosimilar? Are biosimilar like generic medication or not? Sorry أنا تأخرت في إعداد البرزنتيشن فما بدي أحط الأسئلة. Biosimilar medications are highly similar medication. This is a very simple definition، ولكن خلنا نشوف التعريفات الموجودة من الجهات الرسمية والمنظمات. It's more complicated. FDA defined the biosimilar as the biological product is highly similar to the reference product. So في الأدوية العادية عندنا البراند وعندنا الجينيريك. البراند هو الأساسي والجينيريك هي الأدوية اللي تم تصنيعها لاحقا بناء عليه. في البيولوجيكال والمونوكلونال انتيبودي البايوسيميلر we have reference medication اللي هو الدواء الأساسي and we have biosimilar اللي هي الأدوية المستحدثة منها. Products are as highly similar to reference product, notwithstanding minor differences in clinical inactive components component, there are no clinical meaningful difference between the biological product and the reference product in terms of safety, purity, and potency. EMA, كيف the definition? Biosimilar is biological medicinal product that contain a version of the active substance of an already authorized original biological medication, medicinal production, reference medication, medicinal product. Similarity to the reference medical product is in terms of quality characteristics, biological activity, safety, and efficacy based on comprehensive comparability exercise need to be established. World Health Organization gives simpler and shorter definition. Similar biotherapeutic product is a biotherapeutic product that is similar in terms of quality, safety, and efficacy to an already licensed biotherapeutic product. تقريبا عندنا كلمات again matching في كل التعريف. FDA highly similar, no clinical meaningful difference between the biological and reference product in terms of safety, purity, potency. Again, in EMA, they are focusing, they have the same words: safety, efficacy, potency. Similar product or similar biosimilar come from quality, safety, and efficacy. So it's take one from EMA and one the match and two matching between two definitions. So simply البايوسيميلر أدوية بيولوجية يعني ما نقدر نقول طبق الأصل، لكن نقول متشابهة إلى حد كبير جدا مع البيولوجيك أو مع الريفرنس ميديكيشن الموجود. ما نقدر نقول انها طبق الاصل. ليش؟ لان هيوج كومباوند مو كل الكيميكال ستراكشر جروبز اللي موجوده متطابقه. Step 1 comparative quality studies, the analytical study conduct for physical and chemical properties, and then the functional comparative quality studies focusing on biological, pharmacological activity. And step 2, if the medication are all the comparative quality studies done and proved the similarity, go to step 2, which comparative non-clinical study in pharmacodynamics and toxicology effect. And finally, in step 3, a comparative clinical study, which focusing on pharmacokinetic, pharmacodynamic efficacy, safety, and immunogenicity. If the new medication or new active substance pass all of those 3 steps, at that time we can say this is a biosimilar medication. In terms of comparative clinical safety and efficacy assessment for biosimilarity, for biological medication we have a lower regulatory size. التركيز الأكبر أثناء في البحث عن الإيفيدنس والداتا أثناء اعتماد الدواء. في البيولوجيك molecular characterization هذه تأخذ أقل جزء هي الأساس. Then we go to non-clinical studies, the medication pass molecular characterization, go to non-clinical studies, and then go to phase 3 clinical studies. Both of those 3 phases are lower regulatory emphasis. Main focus or the high regulatory emphasis are the last 2 phases, phase 2 clinical studies and phase 3 clinical studies. This is in terms of biology, biological drugs. In terms of biosimilar, the basic or the higher regulatory emphasis are the physiochemical characterization. Why؟ احنا عندنا دواء already موجود، فدراسة كل الخصائص الكيميائية والفيزيائية والفانكشنال الموجودة فيه تعتبر جزء أساسي جدا ومهم لإيجاد لإثبات السيميلاريتي. That's why functional biological characterization and physiochemical characterization of the biosimilar take a main part, and it's the largest part in the study or in the assessment of biosimilar. Then non-clinical studies must take high regulatory emphasis, just a symbol. Pharmacokinetic, pharmacodynamics, behavioral of the biosimilar medication, again, it's considered a high regulatory requirement. And finally, the clinical studies. The main goal for the final part of the clinical study is to demonstrate no clinical meaningful difference from the reference reference product, rather than independent demonstrating the safety and efficacy of the biosimilar product. This is the track of biosimilar approval, starting by reverse engineering, as I mentioned before, studying all groups, all features, physio and chemical features of the monoclonal antibodies. Then cell culture condition and producing the proper cell culture and producing the proper media or living system. Then testing the function group and finding the formulation. We can have sub-Q reference biologic, and on the other hand, we have IV biologic. So the physical and chemical properties of the reference product must be studied very well, and all of those evidence will be introduced to regulatory body at the country or at the factory physical location, like FDA, EMA, etc. And again, the biologic manufacturing keep running in this track till it gets the final regulatory approval. The study, the main study, as I mentioned, is for the physicochemical and biochemical analysis affected by a huge number of attributors. We have product-related substances and impurities, and we have process-related impurities. Mainly, as a pharmacist or clinician, we are not focusing on those. That are mainly manufacturing issues. So let us have a simple generic comparison between the generic and biologic, as well as the biosimilar medication. In terms of cost, generic medication, to develop a generic medication costs $2 to $3 million, while the producing of biological medication, it costs plus minus or about $800 million. Biosimilar, as we say, $100 to $300 million. So التكلفة الإنتاج أو التكلفة هذه نوعا ما منخفضة مقارنة بالبيولوجيك. Time to market من بداية البروسيس للتصنيع إلى وصوله الأسواق فيما يخص الجينيريك 2 to 3 years. البيولوجيك take 8 to 10 years. Biosimilar تاخذ فترة أقل 7 to 8 years. Clinical studies, mainly the clinical studies for a generic, are bioequivalence studies in healthy volunteers. Why? Because it's identical chemical structure. In the biologic, focusing on phase 1 and phase 3 studies, as we saw in the previous slide, efficacy and safety studies are main concept. In biologic, pharmacokinetic comparison study in phase 3 are the most important clinical studies run on that medication. For patients, to be used in clinical to recruited in clinical studies, in generic 20 to 50 patients, in biologic 800 to 1,000, in biosimilar less around 100 to 500. Post-authorization activities, pharmacovigilance are the most part or most important activity for phase 4 or post-marketing studies. And in terms of biology, we have phase 4 risk management plan including pharmacovigilance as well as the biosimilar. مثل ما نلاحظ هنا في البايوسيميلر سواء تكلفة الإنتاج أقل، الوقت اللازم لإنتاج الدواء أو لبدء تصنيعه إلى خروجه إلى الماركت أقل، العدد الاندفيدوالز اللي يحتاج عليهم في الدراسات أقل. كل هذه الفترة السنتين الفرق هذه فيها علماء، فيها ساينتست، فيها تكلفة إنتاج as well as التكلفة الأساسية اللي موجودة. هذا راح يساهم عندنا ان الاسعار البايوسيميلر يوم تطلع للماركت راح تكون اقل بكثير من اسعار البيولوجيك، وراح نشوفها. هذا البايوسيميلر ماركت between 2019 to 2027 كان فيما يخص طبعا البايوسيميلر. في 2019 طلعت الدراسه اليوروب ماركت is the highest market in terms of biosimilar, then North America. After that, the Asia Pacific and Middle East and South America are almost same. نسبة نمو مثل تقريبا لو compound annual growth rate أكثر من 23%، اللي هو نسبة النمو الاقتصادي على المدى ال9 سنوات أو 8 سنوات الاقتصادي هذه من 2019 إلى 2027 يمثل يعني حسب التوقعات إن في 27 بليون US دولار. إذا جينا نشوف are the most or the في 2018 أو 2008 دخول البايوسيميلر مع الريفرنس برودكت سبب نزول في السعر بما يعادل 39% نزولا. دوس 39% ساعدت في انخفاض حجم المبيعات حقه وحجمه في السوق بما يعادل 25%. while the evaluating 2000 anti-teen fertility insulin oncology medications في 2017 ساهمت في خفض ما يعادل 3% من سعر الأونكولوجي expansion، وساهمت في خفض ما يعادل 6% من التوتال من التوتال ماركت للبايوسيميلر and references product. What does that mean and what that's important؟ في الإنفاق الصحي. for example عندنا في المملكة تقريبا ميزانية الأدوية تقريبا يعني 3 مليار. زيادة الحالات والأدوية الجديدة هذه كلها أدوية مع هاي تكنولوجي، أدوية أسعارها نوعا ما تكون مرتفعة وغالية. زيادة ارتفاع الأسعار هذا يمثل عبء على الأنظمة الصحية في كل دول العالم وليس مثلا في المملكة لوحدها أو في دولة بعينها. That's what a lot of guidelines and limitations in front of patients. إذا عندي والله مثلا 5 مليون أقدر أنا أعالج بها مثلا 10 مرضى أورام، أنا ممكن ال5 مليون هذه أقدر أعالج بها 20 مريض. evidence based decision وليس emotional. ما نتكلم بالعواطف، نتكلم بلغة الأرقام وبالديسيجن ميكر language. So كل ما نزلت الأسعار كل ما ساعد أنا أعالج مرضى أكثر، كل ما حقق لي فاليو أعلى من مجرد الكوست. يعني الفاليو الأوت كم فاليو حتكون أعلى من لو كان استخدم الريفرنس دراج أو تكون السورسز حقي نوعا ما محدودة. Why are biosimilars important؟ زي ما قلنا دخول البايوسيميلر للماركت حيزيد التنافسية. البايوسيميلر itself أرخص من ناحية السعر من الأدوية الريفرنس برودكت. هذا راح يساعد الأنظمة الصحية على توفير أدوية بكميات، توفير الأدوية لمرضى في الوقت اقصر من الوقت اللي كانوا يحصلوا عليه للريفرنس برودكت، راح يساعد معنا في تغطيه شريحه اكبر من المرضى، وبالتالي مخرجات نظام صحي افضل من ما قبل، يعني قبل دخول البايوسيميلار. So those are most 5 steps for importance of biosimilar either in oncology or in other specialty. Increase use of biologics add potential lower cost to the healthcare system, potential access to treatment which may lead to improved health outcome and provide physician with a greater choice. تقريبا الفيزيشن يعني يحب يكون نسميه المنيو ده مفتوح لكل الادويه، ما يحب انه يكون في عليه اي ريستريكشن. الريستريكشنز اللي معموله ليس لمجرد يعني وضع الريستريكشن لذاتها، ولكن لاتمام عمل المنظومه بالطريقه الصحيحه. فدخول البايوسيميلر راح يساهم معك انه توفر ادويه اكثر وخيارات اكثر امام التريتنج فيزيشن. Part 1 expanded therapeutic options to patients while potential unlocked resources that can be reversed in important medication patient care, improving patient care, possible savings and efficient to a healthcare system. أنا متأكد إنه الأنظمة الصحية غالباً خصوصاً عندنا في السعودية ما يبحث عن استرجاع مبالغ بقدر ما إنه راح يساهم في improve السيرفيس وتغطية شريحة أكبر من المرضى وتحسين الإنفاق. I have 5 messages to take home. Biologics can be thoroughly analyzed and characterized at the beginning of studying the biologics. Biosimilars are systemically developed to be highly similar to their reference biologic. Biosimilar must meet the same quality standards as originator product. So when we have a biosimilar, that doesn't mean we have a lower quality. No, it have the same quality. Post-authorization study continuous safety monitoring. Biosimilars may increase patients' access to biologic medicines and contribute to savings for healthcare system. Last thing, as a pharmacist and some of us included in decision making in regard to biosimilars, السعر ليس كل شيء. في اتخاذ القرارات we have a value more than price. Packaging مهمة. Education للناس اللي راح تصرف الأدوية. For example مريض كان ياخذ دواء X، خلينا نسمي مثلا هيوميرا، خلينا نرجع للأونكولوجي، النيوبوجين كان ياخذ النيوبوجين الأوريجينيتور وكانت الحمد لله أموره طيبة. جاء المرة الثانية والله موجود البيولوجيك، يوم أعطاه الصيدلي جاء له الدواء هذا غريب علي، يقول والله ما أدري، أتوقع إنه دواء جديد إن شاء الله إنه يكون مفيد. الكلمة هذه بحد ذاتها إذا ما كان الصيدلي على الشباك أو كان الصيدلي ماخذ well training and well education على موضوع البايوسيميلار، هو كذا قضى على الدواء. يعني والله ما أدري ممكن يفيدك، هذا خلاص المريض psychologically is not responding to that medication. حيبقى مريض، حتدهور حالته، حيجيك اليوم الثاني بشكوى او انه والله انا ما استجبت وصرفوا لي دواء ما هو نفس الدواء اللي انا استخدمه، وممكن يروح المريض يحمل نفسه مصاريف اضافيه هو في غنى عنها انه يشتري دواء الاوريجينيتور من برا، وهذا الشيء ان انا ما فالإديوكيشن المانيفاكتشرنج ستابيليتي كم باتش تصنع الشركه. لو جاني والله الشركه تصنع لي باتش واحد في السنه doesn't danger to take a decision اني والله احول المرضى عليه. في other things اللي هو الانترتشينجابيلتي والسويتشنج all this يعني ما اعتقد الوقت حيسمح ولا اتمنى ان احنا ندخل فيها عشان ما نتشعب. اعتقد ان هذا كل اللي عندي اليوم. للاستزاده فيما يخص البايوسيميلارز انصح بشده بموقع جابي. طبعا موجوده مواقع كثيره وريفرنسز كثيره الاف دي اي الايما، ولكن I think جابي is one of the most important and concentrated and precise source for reading سواء الويب سايت itself or الجابي journal. Thank you.
Thank you, Dr. Amr, for your presentation. Please, if you have any questions, write your questions for Dr. Amr. So I think the
طيب الموضوع mainly تنظيمي أكثر من
في سؤال دحين.
Okay.
Is the effect of biosimilar medication different from patient to others?
Along with my experience and or studies, no. And there are more studies about the interchangeability. There are a meta-analysis and for more than 100 clinical studies, and they have the same effect. No, even one patient develop resistance or immunogenic reaction. So we can say yes.
Another question, what's the difference between biosimilar and bioequivalence?
I did that slide. Bioequivalence is in generic medications. So it have the same bioavailability and the same distribution, and bioequivalent mainly in generic medications or chemical medications. In biosimilar, it's different. It's almost highly similar. Or the biosimilar, the bio mean it's come from a living system, so it's similar. Biosimilar is describing the dose group, and bioequivalency are describing the pharmacodynamic.
Okay, great.
Okay. شكرا جزيلا.
Okay, thank you, Dr. Amr. Thank you for your excellent presentation. الله يعطيك العافية. Now, please welcome with me Dr. Abdulaziz bin Ubaid. Dr. Abdulaziz is a pharmacy supervisor in Prince Noura Oncology Center. Dr. Abdulaziz will talk about safe handling of hazardous drug. Dr. Abdulaziz, are you with us? Welcome, Doctor.
Clear? Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, hello everyone. I would like to thank the organizing committee from SOBA for their amazing webinar and course. So my lecture today will be about safe handling of hazardous drug. Can I see the slides, Inas?
It's clear or not?
Clear.
You can see it?
No.
Now, Doctor? You can see the slide? Dr. Abdulaziz, you are on a mute.
Okay.
Okay.
What about
can
now?
You see? Yeah, now I hear you. Can you see the slide?
The first slide, please. I can't see the first slide.
Okay, this is the first slide, the objective.
Yeah. Now, yeah. Okay. So the objective of my presentation is to define the hazardous drugs identify types of exposure, identify personal risk, identify activities that may result in exposure, guidelines for safe handling of hazardous drug, and to identify the best practices in dispensing, preparing, and administering chemotherapy. You know, hazardous drug right now, or the risk in Corona era, I can say it is similar to Corona era. You can hear in my presentation some about the protection, but the differences between the hazardous drug and Corona right now is that we identify where is the hazardous at inside the pharmacy. Initially, USP has a chapter called Chapter 797. It has guidelines for sterile preparation. Now we have the USP Chapter 800, which has guidelines on hazardous drug. And on the screen or in the slide, you can see the USP chapter, the first page. Next slide. So hazardous drugs are defined as any drug which has hazardous effect to the cell. NIOSH, which is National Institute of Occupational Safety and Health, listed these drugs and include cytotoxic, antiviral, immunosuppressant, hormonal, and biological drugs. It is important to know that not all hazardous drugs are cancer chemotherapeutic agents. Next slide. So NIOSH subgrouped hazardous drugs on 3 groups. The group 1 is the anti-neoplastic drugs. Group 2 is non-anti-neoplastic drugs that meets one of more of NIOSH criteria for hazardous drug. Group 3 are drugs that primarily pose a reproductive risk to men or women who are actively to conceive, and women who are pregnant or breastfeeding. NIOSH definition of hazardous drug as a hazardous drug is any drug identified as hazardous or potentially hazardous by carcinogenicity, teratogenicity, reproductive toxicity, organ toxicity, genotoxicity, or any new drug with a structure and toxicity profile that mimic existing hazardous drug. And this is important for pharmacists. If you have a new drug, you have to identify if this drug has hazardous or not. Next slide. So in the normal cell, hazardous drug might have impact on or damage DNA gene, cause cancer, contribute to infertility, impact on developing embryo or fetus, cause developmental abnormalities, cause organ damage, and we know that hazardous drug which has similar structure or function to the drug that are determined by to be hazardous. So the risk of exposure to these drugs might has acute and long-term effect like hair loss, cardiotoxicity, kidney damage, even cancer, hearing loss, nausea, infertility, rash, and reproductive outcome. The side effect of this exposure would be characterized, we have in this slide about the exposure, more than in practice, more than 8 million US healthcare workers are exposed to the hazardous drug every day. The exposure of hazardous drug might come from different steps of handling hazardous drug during preparation, or even sometimes accidental exposure, or during administration of these drugs, or after the preparation and administration, during even the waste collection and medication transportation. So you have to be careful when you are dealing with these kinds of drugs. So ways of exposure could be unexpected or accidental during dispensing, compounding, and other manipulation during administration, even patient care activities or spill might happen during transportation of the drug, and as I mentioned, during the waste. So that's why we have to limit the access to the area which there is a preparation of the preparation of the drug or administration, because there might be inhalation or skin contact, absorption, ingestion, and injection of the or needle stick. So the facilities inside the healthcare, there might be exposure to hazardous drug. It might be inside the hospital, pharmacies, physician clinics, especially oncology clinics, patient treatment area. Of course, there are oncology treatment areas or chemotherapy treatment rooms, the wholesaler or stores which we are storing the medication. So the storage of the medication, of hazardous drug is one of the important factor or the first step of safe handling. There should be negative pressure and separate storage places that are important. Staff who are dealing with these kind of medication, they have to wear the PPE, which are the personal protective equipment during even unpacking. So wherever there are hazardous drug, label of the hazardous drug should be. In addition, hazardous drug shouldn't be placed on the floor, neither above eye level. So they should be on shelves. So shelves should be edges and avoid falling of these of the hazardous drug vials. So for engineering control, if you are interested in designing of chemotherapy rooms, we have to support the safe handling of cytotoxic drug. So we must have a designated area for receiving and unpacking store of stored hazardous drug. And by the way, they are even at the storage. Negative air pressure is essential. 3 rooms should be there, as we have in any places when we are dealing with the chemotherapy. So we should have like office room. We should have ante room, which is another level to the clean room, and at the end we should have a clean room designated for preparing chemotherapy or vials. So we can store chemo at the clean room and unpacked inside the clean room. This clean room should be ISO 5, the anti-room, it can be ISO 7. So we need the clean room to be HEPA filtered. Biomedical engineers should certify the room at least every 6 months. The temperature of the anti-room should be less than or equal to 20 degrees. These are requirements for the vials. I mean or the 20 degree. That's the microorganism will be minimum at the 20 degrees. So there should be special instruction for the chemo room, and should be there for floors, walls, light, windows, doors, benches, chair, trolleys, fire, smoke, alarm, and ceiling. So there should be also waste removal, ways to get out the waste, and there should be like a communication system between these three rooms. So the surface wipe sampling for environmental quality control should be include the interior and contaminant primary engineering control, equipped contained on it, the pass-through chambers, the surface staging or work area near the CPEC, and the area adjunct to the CPEC, like the floors directly under the CPEC, the staging and dispensing area, the area immediately outside the hazardous drug buffer room for the SCA, and the patient administration area. So if it's positive, the action should be taken is re-evaluate the work practice. We have to retrain pharmacist and pharmacy technician, and we have to perform through deactivation, and we have to do decontamination, of course, cleaning and improving engineering control. So for PPE, which are personal protective equipment, first about the gloves that used in the chemotherapy should be American Society testing material, ACTM, should be tested and has this certificate or standard. And the chemotherapy should be worn during the chemotherapy preparation. So it includes latex, nitrile, neoprene, and polyurethane gloves. So the gloves need to be worn all times. This is important during the handling of hazardous drug. Also, double gloving is required. So the gloves which you use inside the biological safety cabinet should be changed from time to time. Sometimes the recommendations say 30 minutes. So the inner glove should be under the neck cuff of the chemo gloves, and the outer gloves should be over the cuff. So there should be no exposed to the skin. So the outer pair of the gloves should be removed after compounding is complete and the final preparation has been whipped off. So the inner glove should be worn with the labeling and checking. When the gloves removed, only touch the outer uncontaminated surface of the glove. The used glove should be placed in the seeable plastic bag or for disposal. So this is similar like what we heard about during the Corona time. So I should say also, we are providing like this lecture for the training. So it should include the practical training. So for whom they are interested in preparation of the chemotherapy, he should follow the certain training. So some hospital they are doing this training inside the pharmacy. So it's not theoretical only. It should be practical. So for the gown, so we have to use disposable gown made of material tested to be protective against hazardous drug. So it should resist the permeability. It should be closed in the back. It should be coated gowns and should not be worn longer than 3 hours during the compounding and immediately after the spill, especially after the spill. So usually in the chemotherapy, it is used half of the day in the morning and another one in the afternoon. So remove gowns carefully and dispose the gown as hazardous drug. So anything used inside the chemotherapy room should be considered as hazardous. Always wash hands after removing the gowns. So for the gowns again, we have to use disposable gown made of materials tested also to be protective against hazardous drug. Sorry about the head, hair, and shoe and sleeve covers. The USB chapter 800 also include the bird cover. So you should cover your, for the men, they have to cover their bird. So the contaminated covering should be discarded as hazardous waste. So the USB requires a second pair of shoe cover, not only one shoe cover, and the disposable sleeve cover made of polyethylene coated propylene and other laminated material. So for the eye and face protection should be used whenever there is splashing or aerosolization of hazardous drug is possible. So the face shield provide better skin protection than safety goggling and glasses. So the surgical mask only protect the preparation. We are using the N95 respirator fit for the initial individual is need to protect both worker and the preparation. So, and also do not forget the N95 and eyeglasses are essential during the spill. These are the recommendation. So the hazardous contamination communication program, it includes the SDS, which is the safety data sheet, and the program include a written plan, hazardous warning, SDS for each used hazardous chemical. So this is SDS like a book for all chemical that are hazardous, and the Sibahi requirement need this SDS to be available wherever there is use of hazardous drug. So the information of the training also we should have for all staff, including physician and nurses. So the personnel must confirm writing and understand the risk of handling hazardous drug. So for personal training, it must include for the safe handling of hazardous drug, the overview of the entity of listed hazardous drug and their risk, and should review the entity of safety related to handling of hazardous drug. And it should include the proper use of PPE, personal protective equipment. So, and also proper use of equipment and devices like the engineering control and the response to know or suspected hazardous drug exposure. It should also the training should include the spill management, what you have to do during the spill, and the proper disposal at the end of the preparation of the hazardous drug and trace contaminated materials. So during receiving of hazardous drugs, we must check the package and the container. If the shipped container appears damaged for these hazardous drugs, a damaged shipped container must be opened in closed environment. So for compounding of hazardous drug, this is just a hint, and it needs a training. Compounding of hazardous drug, it's not an easy task. We are using the biological safety cabinet. It's called BSC, which is biological safety cabinet. It is different than the horizontal hood. So we are using biological safety cabinet to ensure safety for the one who is preparing and at the same time ensure the sterility of the IV chemo drugs. So the biological safety cabinet, like in the picture, has two HEPA filters in this figure. Its blower should be open 24 hours to provide negative pressure. So the vials inside, prepared inside the biological safety cabinet, and it is preferable to use vials over the ampoules, because ampoules has glasses, and the vials we are punching the rubber. So it might using ampoules might injure the one who's preparing. So you can see most of the vials or hazardous drug provided. They provide it in vials. So as shown in no air is going in the figure. There is no air is going outside the biological cabinet to provide the safety, and this ingoing air is not going directly to the preparation zone. The one to the left, or the device to the right, and the one who's preparing will stay to the left, facing the biological safety cabinet. So the exhaust also is also filtered to provide safe air to the environment. So this biological safety cabinet is called Class 2B biological safety cabinet, which is ISO 5 inside the cabinet. So the negative pressure technique. This is the technique that we are using to prepare the chemotherapy. So we need, as I mentioned, we need practical session to illustrate this technique. But in general, this technique avoids the positive pressure inside the vial by using a minimum amount of negative pressure inside the vial, or by using hydrophobic filter needle, the syringe and the syringe tip caps. So the exact volume of the drug required should be measured before the syringe is removed from the vial. So after the drug is measured, we have to turn the vial upright to pull a small amount of the air before removing the needle. So this is a technique is difficult to be illustrated theoretically. It should be done as a practical session. Next slide. Closed system of vial transfer device. We call it CSTD. These are devices. This technique is a new technique. Has been used for the few years ago, and this technique CSTD it added additional protection for workers. From the name of this technique, no air comes inside, outside the device or outside the vial. So there are few companies in market. I listed there. There are Facile, ICU Medical, EquaShield. So by using this device, we will not have any air outside, so it will give protection for the pharmacy staff. So during administration, a well-trained nurse on chemotherapy should take care of the patient. Nurse should wear the PPE and store the chemotherapy away from other medications and at a designated place until the time of the infusion. So the nurse should make sure that the patient sign the chemotherapy consent. A patient should agree before starting. And the patient should be aware of, about the chemotherapy and also its side effect. The nurse should be sure about the identity of the patient and double check this procedure with another nurse. So the nurse has to flush the IV line and to take the extravasation precaution, because this chemotherapy, it might have extravasation. Extravasation means it will harm the skin, and there is rupture from the vein of the chemotherapy from the vein. So it is harmful and it's a serious side effect. And finally, the nurse should dispose all waste by proper hazardous waste disposal procedure. So for the oral chemotherapy, we have to educate patient on how to administer and store chemotherapy to provide safe handling of these chemotherapy. It is recommended to give a written paper on how to use and store chemotherapy. The patient should have a 24-hour access to the healthcare provider, and sometimes simple advice worth a lot for patient. The patient should know about hazardous drugs which need monitoring, and the patient should know about how to dispose the chemotherapy properly. So the spill kit or the spill control, the spill kit should be available whenever we use hazardous drug. There will be should be proper training for hazardous drug spill should be done to all pharmacy staff. There should be proper education for other healthcare providers who are dealing with the chemotherapy, and patients should have and also patients should be trained about how to handle tablet or of hazardous drug. And the following steps should be done. I listed some steps. It also needs a practical session. A spill kit should be available. These are steps: immediate removing of the gloves or gown. We should immediately clean the affected skin, and we should floating the unaffected at the eye wash fountain or with water or isotonic eye wash for at least 15 minutes. We have to obtain medical attention, and we have to document the exposure and the employee at risk. So in the best practice, we have to, as I mentioned, we have to limit the access to the chemotherapy area. These are some tips. And we have to continuous modification on the evidence-based practice. This concerns the medication or handling medication in the pharmacy in general. And also the best practice include the patient education. We have to identify the key information to rely to patient. So for the follow-up plan, we have to apply a well-established competency plan, and we need to stress on proper training to all oncology chemotherapy healthcare staff. And we have also to establish best practice by tracing chemotherapy orders in ordering, preparing, handling, and finally dispensing chemotherapy. So references, if you need to if you like to have more information about safe handling of hazardous drug, you can search about the following. As I mentioned, the USP Chapter 800, also the ASHP, they have safe handling of cytotoxic drugs. Also ASCO, NIOSH, I mentioned the National Institute of Occupational Safety, the OSHA, also Federal Occupational Safety of Health Administration. Also material safety data sheet, I mentioned in one of my slides. And also, even for the nurses, they have the Oncology Nurses and Nursing Society, some tips about the administration of the chemotherapy. So this is the end of my slide and presentation. I hope you enjoy my presentation, and thank you. Any questions?
Thank you, Doctor. Thank you for this informative presentation. Thank you very much.
Thank
Please,
you.
if you have any question for Dr. Abdulaziz, please write it. There is a question. What is the procedure of discarding of hazardous drugs?
For discarding hazardous drug, there are procedures inside the biological safety cabinet, and there is a procedure for the spill if it happens outside the biological safety cabinet. We have precautions inside the biological safety cabinet. We have something called super-serve pads, which absorb if there is any spill, and at the same time you have to clean wherever there are whenever there is a spill, you have to clean the cabinet and clean the area if there is spilled chemotherapy. And the discard of the chemotherapy, if you mean the waste, there are certain procedures. There is yellow bags. We are keeping, we are discarding chemotherapy inside yellow bags, and there is a procedure for the yellow bags. It is considered as a biological waste.
Okay. Thank you, Doctor.
You're welcome.
Thank you. So now, please welcome with me our last speaker for today, Dr. Ali Mahlan. He is a chemotherapy unit supervisor in Dr. Ali will talk about the medication safety on oncology. Welcome, Dr. Ali.
My presentation is okay.
Yes, clear, Doctor. You can start.
Thank you, Inas, for this introducing. السلام عليكم ورحمة الله وبركاته. بسم الله والصلاة والسلام على رسول الله. زميلكم علي ملحان، صيدلي مستشفى الأمير محمد بن ناصر في جيزان. Today I will talk briefly for the medication safety in oncology. Why safety in oncology? Because we are handling with anti-cancer medication that are hazardous medication, and they have a narrow therapeutic index and classified as high alert medication. Many of them is metabolized by cytochrome B450 that lead to more drug-drug interaction and concentration irritation. The drug sequencing may be increased and decreases due to the diagnosis, and dosing may be different due to the toxicities, and calculation and manipulation is based on many factors. To enhance the medication safety and prevent the medication error, we should cover the patient information and medication information and provide or improve the communication of the drug order and the drug information communication and medication standardization, staff competency and education, patient education and quality process and risk management. For the patient information, we need to access all the data regarding the patient, especially for the patient information. Essential patient information should be organized and made readily and accessible for all healthcare provider who is prescribe or dispensing administration chemotherapy. Patient profile should be contain the following data: patient name, identifying code or MRN number, brief medical history that identified the patient's cancer diagnosis, specific and known the drug-related adverse event, allergies, and food sensitive. The vital statistics that maybe affect the treatment intensity, like the height and weight, body surface area, and labs value, data about all the prescription over the counter or the herbal or alternative medication used by the patient. Primary reference that describe the treatment regimen and an up-to-date treatment history, including the treatment cycle, how the previous patient was tolerated and previously drug administered like anthracycline. The medication for the medication information, the factor to consider for the specific medication and cumulative dose, route of administration regimen, and sequence of administration and another treatment, and the compatibility with the infusion fluid and another medication and the pre-medication. For the patient, for the medication information, essential drug information obtained readily and useful for all considered when prescribing or scheduling, dispensing and administration or monitoring. Standardize the medication preparation guideline and standardize the medication storage and medication labeling, and make sure the drug information is available for all healthcare provider. Before we prescribing the medication, the organization and the oncology center should have a policy to support or to decrease the medication error and patient safety. Here we have standardized the medication ordering and schedule or coordinating، لأنه المواعيد دائما في جرعات الكيموثيرابي ترتبط، المواعيد دائما في الأورام ترتبط بجرعات الكيمو، فلا بد إنه تكون الجرعات متناسقة مع السايكلز. Continuous education and competency. Avoid a verbal order for the chemotherapy except at discontinuing, and avoid the stat order for the chemotherapy. It is rare to need the chemotherapy as soon as possible, and standardize the dosage calculation and standardize the medication order content. At the prescribing level, the instruction of the medication regimen should be explicit, complete, clear, and easy to follow. The treatment regimen should be described accurate. The patient medical record should be contained, and prescriber should uniform the note for expression, the quantity amount, like dose and concentration, volume, and time. Prescriber should never write whole number with decimal point if the dose is more than 1, and if it is less than 1, we should write than 0 before the decimal. All the treatment plan and the medication error should be identified, the dose and the calculated dose, total course total course dose should be included. All the medication that are a part of the treatment, like supportive care, antiemetics, and so on. Medication preparing and dispensing. At the medication preparing, we should standardize, as we said, the medication preparation guideline. In the chemo pharmacy, we should establish a standard guideline for reconstitution, dilution, packaging, and labeling. The orientation on the medication error reduction, and pharmacy supervisor and the manager should be develop an orientation program about the medication error commonly and associated with the chemotherapy medication for training of the pharmacy personnel who is prepare and dispense the chemotherapy. Standardized labeling, we should establish a procedure should be established for the standardizing the medication labeling. Uniform systemic labeling method should be used, especially when the multiple drugs are prepared for a single patient. Patient name and identifying code and MRN number should be appear in the label. Generic drug name, the amount of the medication per container, and when the product container hold more than doses, like the multiple doses for the same patient, and how much overfill added to the container, and route of administration, especially when are administered other than IV route, especially for the intrathecal. The name and amount of all drug additive to the chemotherapy, like the platinum, cisplatin, we add the magnesium and potassium should be written, the name and the amount of the additive. Diluent name and administration rate and duration should be put in the label, and when necessary to prepare more than medication, and sequential administration container label should be a number. يعني like إذا كان عندنا مثلا بروتوكول من 5 أو 6 مثلا أدوية، we should write one of 2 or one of 3 and so on. Expiration date and BUD should be written, and caption label required for the hazardous product, and storage specification, and the name of the institution and pharmacy which is the dispensed medication. And patient education and counseling. We should educate the patient and counsel them the purpose of the medication and its use, and the appropriate use and the safe handling for the medication, and appropriate the temperature and the safe storage condition. Special precautions for their families who is handling with this patient, and to avoid the exposure to the hazardous agent which is found in the patient fluid and his linen and clothes. And the potential interaction and another medication and food, and what to do if the dose missed, and dosing calendar and tools to improve the adherence. Common and possible associated side effect associated with the medication, and what to do if the potentially serious adverse effect occur, including the contact with the provider and who to contact and how to reach them, like bleeding, uncontrolled bleeding, uncontrolled nausea and vomiting, and how to probably dispose the medication container and supply because it's cytotoxic. At the level of the administration, nurses often the last link in the chain of the healthcare provider who is provide the treatment with the chemotherapy medication. to safeguard the patient from the mistakes. It includes standardized the medication and medication administration practice, and standardize the tool of the medication administration record, such as worksheet used for calculation dose and lab results. Checking order and administration equipment, and recording the tracking chemotherapy use. To identification and managing medication error, implement and monitoring intervention, controlling injurious effect and ensuring the patient safety, and determine whether the error could have previously occurred with a barrier treatment, same patient or another patient, and seek with advice healthcare professional from the various disciplines, and determine whether the immediate, temporary, or the stop-gapping change in the policy and the procedure necessary to prevent the recurrence medication error. Provide immediate professional counseling employees implicated in the causing or contributing to the error which is result of harm to the patient. Establish a procedure to inform and follow up with the patient and their families about the medication error, and understand that the reporting of the medication error and adverse drug reaction is responsibilities should be shared by all healthcare providers. Encourage a practitioner to reporting the medication error and the national medication error tracking program زي اللي موجود في MOH. عندهم tracking program للميديكيشن error في كل مستشفيات MOH في المنطقة في المملكة. This is an map for the cycle of the chemotherapy protocols from the prescribing to administration. All this checkpoints يعني كل الcheck points هذه المفروض إنه كل واحد يأخذ responsibility to evaluate the order and evaluate the product and evaluate the patient as well. من البريسكرايبر إلى الفارماسيست والنيرسز وحتى البيشنت themselves. That's all, and thank you.
Thank you, Dr. Ali, for your informative presentation. Please, if you have any question for Dr. Ali, ask in the chat. They are thanking you, and I think they haven't questioned.
Thank you, Ines.
Thank you, Doctor. طيب أول حاجة حابة أشكر السبيكرز. شكرا لكم جميعا على your efforts. Thank you for making this course successful. Thank you for your attending. شكرا لكم، ساهمتوا في نجاح هذا الكورس. بس أول حاجة حابة أقول لكم إنه بالنسبة للشهادات، اللي بيسأل عن الشهادات بإذن الله حتوصلكم خلال 2 إلى شهر. اللي مستعجل عليها بس يكلمني على الرقم اللي موجود. ثاني حاجة حيوصلكم سيرفي. بليز answer على السيرفي هذا قبل استلام الشهادة. Your comment is really matter. And thank you. Thank you all.